Professor Robert Winston. It is my great privilege and pleasure to welcome him today in the waiting room. As with so many journeys, may I ask a little bit about where you grew up and about your wonderful parents?
I grew up in Southgate in North London, Northwest London, North London. My father was, he had a diamond factory. Actually, it's not, those days diamond craftsmen worked in threes and fours, so having four people on the bench was massive. In fact, I think he handled quite a big proportion of diamonds coming in from the continent. He was good at that too, I think, and he was a polymath. He was a fine musician, a good violinist. He was an actor. He was widely read. He had a whole lot of different strings to his bow. I think he was completely impossible. And my mother loved him absolutely dearly, but they used to fight all the time, and it was great because actually they never really took that very seriously. My mother was an extraordinary person. She was very brave, very socially committed. She became mayor of the borough that we lived in, and was a highly successful mayor at that time.
May I ask about your relationship with your father and your mother in turn?
Well, my father died when I was 8. He had a very sudden illness, and I mean, a complicated story, but he basically just had a chill. He wasn't very well. He got a bit of pneumonia. He eventually then got some form of bronchitis. I mean, he was a completely well 42-year-old. He got an abscess in the lung, so he got and that was drained inadequately, I think. He was given, this is after 1948, so he wasn't given enough penicillin either. And I think then, I mean, cut a long story short, after a long illness of about 6 months, he had a metastatic abscess in the brain.
At that time of his illness, do you have any memories of him being treated? And
Yes, I do. I remember visiting him in hospital. I remember my mother bringing in a little bag of diamonds, which his staff, one of his diamond cutters, had cut, and they were in a little bag. They were obviously quite precious. And my father, who was lying in bed, who wasn't very well, took out a wine glass and looked at them like this, and then he swore, and he threw the whole lot down the bedpost like that.
bless
He
him.
thought they hadn't been cut well enough. So then my mother was scrabbling around to try and get these diamonds back out of the sheets. This was in a hospital bed.
Yes. What was your inspiration, aspiration, and that led you down that path of wanting to become a doctor?
I was 16 when I did my first in vitro fertilization, because I fertilized sea urchins' eggs and watched them develop under the microscope.
Wow.
And it was stunning. And you might think that would inspire me to do IVF. It didn't. Of course it didn't, because actually it was just wonderful to look at the biology, but I didn't, in fact, think about doing IVF. In fact, everybody said doing this in mammals, of course, or any vertebrate species is completely impossible. That was the general view. But it is interesting because one or two rather unpleasant individuals who have big private practices, which I've always criticized in IVF, often said that I wasn't a pioneer. But actually, of course, I was doing IVF when they were still in nappies, which I find rather amusing, actually. So I won't mention any names, but it just make me giggle. But I mean, when I finally did do IVF, I was a Luddite. I mean, I didn't really think it was going to be successful. I knew by that time it was obviously going to be done, because this was in 76. I started trying to do it, and in 78 there was a baby from Steptoe Edwards. And so it was obvious it could be possible, but I was still a Luddite. I still didn't think it was that worth doing, although I was doing it and trying to do it because I felt it was interesting scientifically. Yeah. But I couldn't see how a health service, which was so stretched, could possibly provide what would be needed for it. And it seemed to me, therefore, it was going to be so expensive that really people would want to do it. I was completely wrong about that, because actually it did become, a major service. But unfortunately, sadly, it got very privatized, which I think was terrible. And I must say the people who were pioneers were partly responsible for that.
How was your medical school career before you graduated?
It was wonderful. I didn't do any work at all. I didn't go to lectures. It was very freewheeling. I played a lot of chess. I did a lot of sport. I certainly got rather better marks than one could have expected, certainly. But I think the clinical medicine, just sitting with patients and talking to them, was something that I was very much encouraged to do. We went to, in the clinical course, the clinical course was at the London, and, that was highly, it was highly clinical. Our consultants were appalling scientists, but they were good doctors. They were very good doctors. And they were amusing, and they were off the wall. I mean, they were outrageous. They did things which would be politically completely incorrect now.
Sure.
I remember one occasion, well, there are so many examples. Dr. Hunter, who was one of the first people to really get involved in diseases which were, if you like, contracted in the workplace. So he was interested in asbestosis, pneumoconiosis. He wrote the definitive book on industrial disease. On one occasion, on our first ward round, he came into the ward. I could imitate him now. He bounced in like an ape. We were 6 medical students waiting to go on the ward round, terrified that we'd heard about this man. And he came and boom, like that. And he looked round at us like a gorilla. And then he said, "Sister, where's the first patient?" So we walked up to the first patient, and the clinical clerk, one of my colleagues, thank God it wasn't me, presented his assessment of the history and so on, and what he found on examination. And Hunter grumpily took his notes from him. "Let me see. No, I don't want to see the doctor said. Let me see your notes." So he handed them over. He went through them, put him on the floor. And then, "Well," he said, "this man's got pain in the abdomen. Where's the picture?" "Old Chinese proverb, 1 picture worth 1,000 words," he said. "Sister, where's the body stamp?" The thing that you put in the notes, which gives you a little picture of the abdomen. So Sister knew what was coming and was very reluctant to get the body stamp from her office, but finally she was persuaded, so she brought the body stamp back without the ink pad. "Sister, where's the ink pad?" So she went off and got the ink pad, and he stamped it like this. And then he took my friend and he stamped his white coat on the left side, on the right side, round the back, on his forehead. He got down on his hands and knees and he stamped the hem all the way round. He was covered in body stamps. Now, this was in front of all the patients, which was a great show. Mm-hmm. And everybody was absolutely amazed. And now, of course, you probably get sued for bullying or for, it would be completely inappropriate to do that in front of a patient anyway. The patients loved it. It didn't do any harm to their medical career at all. And did my colleague want to complain? No, on the contrary, the thing he wanted to do is to keep the white coat.
Can you remember any more stories when you graduated and were on the wards seeing patients?
Well, I think I've probably told you this story. I mean, my first patient as a doctor, I had no idea what you did as a house surgeon. I was locum, really, of course, it was just a filling in. This woman who was, I think, probably close to about 70, who was filthy. I mean, she was totally unkempt, and she was brought in unconscious straight from the receiving room and put in the ward while she was they had decided what they were going to do with her. I think the receiving room was quite full, that's why they sent her straight up. I was on the ward and asked to see her and examine her and assess her. And she was unconscious, and she had very dry skin, she was obviously dehydrated, not surprisingly, and as I sort of looked at her, I could smell ketones. So I made the assumption that this was probably a diabetic coma, because I'd learnt that much. So I put a drip up. Fortunately, I put a drip up. That was not very easy, but I wasn't too bad with my hands. One of the great things our course was it was pretty practical. So slipping a drip into somebody who was a bit not very well wasn't so impossible. And I got a drip up first time, actually. Mm. And we ran I'd told that you did put some sugar in, so I put a weak dextrose solution in rather slowly. And I took blood. Thank God. I took blood and sent it off for electrolytes and blood sugar and so on. And then I said to the nurse, look, we must get hold of the registrar. I'd already asked her to do that, and we bleeped the registrar, and he wasn't around. Couldn't find him. It was at the middle of the working day, about lunchtime. So then I said, well, we better get hold of the senior registrar, and he wasn't available either. Well, the consultant wasn't in the hospital, so I was stuck on my own. So I said, well, I really think this is an emergency. We need to give some insulin. So I'd read what you do, so I thought, well, if you give half a dose intramuscularly and half intravenously, that probably might be the right thing. So I asked her to draw it up, and I injected half of it intramuscularly, half intravenously. But of course, nobody had ever taught us that you check the bottle. I could see it was insulin, but what I didn't notice, of course, and didn't check properly was that it was quadruple strength. So she ended up with, I think, 200 intravenous units.
God. And what followed?
And then, of course, my two registrars both arrived. They'd both been in different pubs in Whitechapel. They were very angry. Of course, they were all frightened because they thought I might have killed her. Anyway, what was really interesting about that was that when her electrolytes came back, her potassium had swung from the fatal end, because she was so badly, ketotic, to the other end where, in fact, her heart might stop any moment. You see, this potassium was, completely awry.
Absolutely.
Anyhow, the following day, the consultant came in and told me that really I'd been very lucky and I shouldn't do that and all the rest of it. And that he was pretty, he was pretty firm. Mm. And then he said, "Oh, by the way, you did probably save her life."
And this is in the early years of your
Yes.
first patient. One thing I feel that we have lost and maybe has been eroded is the majestic and ever-present matron or sister of the ward. And do you have any stories or experiences of them and the role they played in your
Yes,
career?
they were really very much in charge. And actually, I think the ward sister and was a key figure. And I think that's been lost because they really provided the sort of continuity you need. I remember on one occasion, I think I was on the house by then in some peripheral hospital somewhere, and I went to the Cardex, which is where they kept all the nursing notes from overnight. I wanted to see how my patients had been, really. And the sister came up and she saw me handling the Cardex. It was a big metal Cardex, and she took the cover of it. She slammed it down on my hand. She said, "That's ours," she said. It was quite authoritarian. Medicine was very authoritarian.
And you've alluded to some stories that you wanted to tell us about the authoritarian nature.
Well, I can't mention the name of the consultant, even though he's not alive now. His son is practicing somewhere in London. So he did bilateral adrenalectomies in these patients, but he did them through the abdomen, which is probably the right way to do it, but it was a pretty major operation. And all I was there to do was to retract the liver for 3 hours, which was not great. It was not exactly a great teaching thing. At the end of the operation, the anaesthetist, I remember my first case, said, well, I'll give my usual dose of hydrocortisone, he said, to give her, top her up and so on. And then as she was being wheeled out, I said to the surgeon, "Excuse me, sir, obviously she'll need a further dose tonight, and there's nothing on the notes. What should I give her as a maintenance dose?" "Oh, she doesn't need that. She won't need it." I said, "But I really think she will need some steroids. No, my patients do not need steroids." That's what he said. Well, maybe he wasn't removing the whole of the adrenal. I don't know. In other I have no idea. Anyway, I was uncomfortable about that, but he was very cross that I'd even asked this question. And I went up to do my night ward round before I went to bed at about 1:45. And the patients we'd operated on, there were 2 others, were fine, but she was there with a very low blood pressure and a racing pulse, so she wasn't bleeding. No, sorry, I got it wrong. Her pulse was normal, but her blood pressure was low. And she obviously wasn't bleeding from the operation, but it did look to me as if she was in shock. And actually it looked pretty serious. And there was no sister on the ward at that time. It was the night staff. So I rang my senior registrar, and by this time it was about 1:10, and woke him up, and he sounded very sleepy and very grumpy. And I called them, you called your senior registrar, "Sir, You know, it was that authoritarian. And I said, look, forgive me. I'm very concerned that I think this woman may be shocked because I think, you know, she really needs some steroids and I want to give her some hydrocortisone. And he said, well, you know perfectly well that Mr. X, I won't name him, does not give his patients steroids. And he said that to you in the theatre. I said, yeah, but you know, this is an emergency. I said, do you think I should ring him? He said, I suggest that you don't do that. So I said, well, look, I'm sitting here with a collapsed patient. Will you come and see her? No, he said. There was a long pause. He said, well, I think what you should do is to give her some hydrocortisone. I'll leave it to you to work out the dose. Don't write it on the chart. And make certain she's got observations going. So I gave her some intravenous hydrocortisone and some intramuscular stuff as well. And I said to the nurse, look, you know, I want you to do 15-minute observations, blood pressure and pulse. And if there's the slightest downward trend, phone me. But in any case, phone me at 4 o'clock to let me know how this woman is. The phone call didn't come through. I think they felt, well, you know, I'd had a pretty rough day. They didn't want to disturb me, which was kind of them. The following day, there was his sort of big ward round, and his big ward round was associated with visitors who used to come with him. So there was one guy from Vienna and a couple of Americans, and you know, they're all big name, well, big sort of surgical interest stuff. And we started on the ward round, and we came to my patient, who he'd done the adrenalectomy on, or his patient who'd done the adrenalectomy on. And there she was, sitting up in bed, eating a piece of toast.
Thank goodness.
So he looked at her, and he went to the drug chart, and he looked at the drug chart, and of course the drug chart was blank beyond the post-operative pain-killing drugs. And I think the drip said stuff. See, Winston, I told you, my patients don't need steroids. And he walked on to the next bed.
Gosh.
That was a deeply influential moment in my career, and actually it was one of the reasons why, it's not the only reason, but I decided to give up medicine, and I did. And I did theatre. I went and directed, which was the other thing I was enjoying doing, and I'd formed an amateur company which I was still running in London, and I used to drive into London occasionally and so on, and whenever I could when I was off, and I was doing quite a lot of acting, which, you know, but I wanted to direct really, and eventually I took something up to the Edinburgh Festival, which did rather well, and you know. But I've never forgotten that, and I remember the guy well. I don't think he was a bad man. He was certainly a good surgeon technically, but he was extremely top down, and I don't think you should ever terrorize your junior staff.
Absolutely. Perhaps in an echo of the polymath nature of your father, I'll add to the detail of your director's career. You won the National Directors Award at the Edinburgh Festival in 1969.
Yeah, I got a silver, 69. I was given a silver cup by Edward Heath, and you can see what sort of man Edward Heath was, because he had this cup, he handed it over to me. He didn't even look me in the face, didn't look at the cast who I tried to introduce him to, and walked off. And I thought, my God, you know, this is not a great politician.
And Prof, my natural question will be, during those wonderful years that you were directing and acting, was there something that eventually drew you back towards clinical medicine?
Well, first of all, doing medicine, of course, makes you really, really good at theatre. Because, you know, surgeons and physicians, a bit like barristers, because they have a similar sort of need for language, are both very good at presentation, acting, and of course, if you go to the Inns of Court, you'll always see baritons somewhere doing some amateur production, which is usually very high professional. And many medical schools used to produce Christmas shows which were really wonderfully competent. The company I formed was a part professional, part amateur company, so I had young professionals, mostly from the Hampstead area, which is where they generally lived because it was cheap then, and a whole lot of ex-students. Now, one or two of them, who I lost touch with after we won that prize, I'm now in contact with. You know, one's a senior company director, one's a member of the House of Lords, by the way, quite funny, interestingly, who resigned from the Labour Party when the anti-Semitism came up, but then in fact he's now rejoined it. So I mean, it's quite funny, really. But that was a talented cast, and they were terrific, you know. But you know, when you're directing, you know, you're looking at human nature, and you're trying to work out what humans feel and think and do, and their emotions. So it's very parallel. And indeed, directing for me was hugely helpful because, you know, it changed the way I write, it changed the way I actually think about patients, it changed the way I do my medicine, the way I teach, I think. I think it made a major difference the way I lecture. And of course, you also have to run a budget. You know, if you're working at the Edinburgh Festival, you've got a lot of people. I had 35 people in that cast. You know, it's a big budget just to house. So you need to get the logistics going. And so actually you end up being, you know, able to organize a small company. Now, of course, I did have an assistant director to help me, who was wonderful, and he taught much of that load off me. But nonetheless, you're still responsible for that.
We have had physicians, we've had nurses die following night shifts because they've not gotten enough rest. And there have been huge changes since the time that you were practicing about the way that healthcare professionals do nights and do on-calls. Can you tell us about some of the more difficult on-calls that you've had to do and the work patterns?
I mean, I was not on call on one occasion. It was Sunday afternoon in the doctor's mess in this hospital in Essex, and at this phone rang in the doctor's mess, and it was the casualty officer who was obviously worried, and he said, and he phoned and he said, look, I've got this patient down in, I think she's got appendicitis, but you know, you're the only person who's sort of surgical around. I can't find the surgical registrar. Do you mind coming to have a look? And I sort of grumped a bit and went down there and saw this girl. Cut a long story short, there was enough about her made me feel that she certainly didn't have appendicitis, but she was 19. She told me that she could never have been pregnant because she'd never had sex. But I formed the feeling that she had an ectopic pregnancy. And to cut a long story short, as I sat there wondering what to do about her, her blood pressure started to fall, her pulse started to rise. She was clearly bleeding internally, and I knew she needed to be opened very urgently. We put a drip up, got some blood for cross-matching, got some O negative ready, and I actually pushed the trolley down to the theatre myself, asked them to call the anaesthetist, who was a locum who I had never met before, told them to get hold of my consultant to come in. Anyhow, when I got in there, the consultant, the anaesthetist, who was quite about 20 years older than me, refused to anaesthetize her. I can't anaesthetize this patient because she'll die, he said. You know, she's too sick, her blood pressure's too low, it's hardly measurable. I said, well, if you don't anaesthetize her, she's going to die. I said, you know, and we argued. I said, you know, this is actually my case. I have to take responsibility. If you're not prepared to anaesthetize her, I'm going to open the abdomen anyway. And I put her on the table. I didn't wash properly. I put a pair of gloves on, and I did start to open the abdomen, and then he put a tube down. And of course, you know, thank God, when the abdomen opened, when I saw the blood cascading all over the floor, I didn't have a sense of fright. I had a sense of relief. I knew I'd done the right thing. I felt, thank God, you know, that's what it is. And of course, you know, it's surprising. It's a very rare thing, and I don't know why it happens. But the moment you identify the ectopic and you clamp it off, the blood pressure starts to respond almost immediately. It must be hormonal. I don't know why it happens, but it happened. And within a minute or two, you know, she was completely under control. And, you know, I washed out the abdomen. I took off most of the fallopian tube, which I probably wouldn't do that now, but I did then. Sewed her up, and she walked out of hospital 6 days, maybe 7 days later, and still denying that she could have been pregnant. I had the fetus in a tiny little sack in a jar.
Amazing.
Well, she was a country girl, you know, and she told her parents she didn't have a boyfriend and all the rest of it. Yeah.
Amazing. Thank you for regaling that story.
Now, I mean, you know, it shows me in a good light, actually, that story, but it shouldn't. What it should actually tell us is that we're missing something in the health service now, because if I tried to do that now, or you tried to do that now, you would be in front of the medical director. The medical director probably wouldn't be a surgeon, and he would actually suspend you, and you would be lucky to get back. And of course, there's a possibility that that patient might have something else. There's a possibility that patient might die. You are very vulnerable, and in the present health service, that's a really big problem.
Some of my last questions for the clinical side of your career: were there times when you experienced absolute joy for the work that you were doing?
Oh, many times. I mean, endlessly. I mean, the great thing about clinical medicine is, that you might do something quite trivial, the patient thinks it's wonderful. You might do something amazingly advanced, which the patient doesn't realize. It doesn't matter. You get your reward, and of course you also get deep depression when you realize things don't go the way you wanted. But you have to analyze what you did, and I think it's quite important. I think one of the really key missions also is not to be arrogant, because it's very easy to think you've been very successful at that, and not to think you can't improve it, because you always can improve everything you do. So I think that's important. It's probably more so in science, where I think arrogance is really dangerous, but there are an awful lot of doctors who are arrogant. I mean, it's really interesting. I think in our training, maybe in the pressure that we're under, and that pressure that you talked about, which I fully understand, I think we forget actually that we're in the best profession. I'd do medicine again. I know that doctors are leaving. I know that there are many people leaving early and retiring. I think that is sad for them, men mostly. I think it's a kind of failure for us. I think it's something which is disastrous for the health service. And I think it's bad for the morale of everybody, because a 65-year-old has a lot of wisdom there, because they've made more mistakes than the 55-year-old, and they've made more mistakes than the 45-year-old, and therefore that needs to be valued.
Absolutely. Prof, in every sense, you are a pioneer in the field of fertility, and this is evidenced by your numerous publications, which are there's far too many for me to quote.
And most of them are crap, by the way.
No, they're not. No, they're not. Your work in the media, your work with children, and perhaps more importantly, and what I'm alluding to, is the work that you've done in women that has allowed them to have families. And there is no questioning that. And I have evidence of that. Can you tell us about any of those stories where you have brought hope to those women?
I was standing on a very busy platform where there were a lot of English speakers in Paris, the Gare du Nord, and this huge woman who must have been, I don't know, a second row forward probably for Toulouse. She was massive. I don't know if women play rugby down in that part of the world, but certainly the male do. But she was huge, and she grabbed me by the shoulders, and she shook me like this. And I looked up at her. She said, "You got me pregnant!"
And what were your feelings at that moment?
I wanted to run.
Truly amazing. The NHS have played a role in your life, and there have been instances where you needed the help of the NHS.
Well, yes, I mean, of course, not much actually. I've been pretty fit so far, thank goodness. I have to say that it's still playing a role in my life, because actually, I'm a member of the House of Lords. We've got the healthcare bill going through. If I was to speak politically to you at the moment, I think it's a disastrous mistake of the government to put this bill through at the moment. I think it's completely unreasonable. We need to be doing a real assessment of what happened during the COVID pandemic first in hospitals. We need to give the NHS a chance to rest and recover and think about things. We've got a massive backlog, and the time will come when we may need to reform as such. But the idea of a new Secretary of State coming in 1 month and saying we're now going to reform and renew is completely nonsensical. And it's shameful that the government can speak like that. It is shameful, because it shows a lack of a sense of responsibility for the health service and for the people who work in it.
There are doctors, nurses, receptionists, porters, medical students, nursing students who feel burned out, disillusioned, undervalued within the NHS here and healthcare professionals around the world. As someone who has done so much for healthcare and science and academia and patients, what is your message for them?
Well, I think I've pretty well said it. The fact that people will remember you afterwards, no matter. Even if you're a porter, I say even if you're a porter, but if you're a porter, for example, or if you're a consultant. I think we have to support each other more. I think that's really important. I think we have to understand how difficult this is. It's very difficult when you're the clinical director of a team and you've got a responsibility for getting patients through, but ultimately, I think we have to stand up to what we think is incompetent management or management which is under stress through no fault of its own. Because I think, there's some very good management in the health service as well as not so good. But I think above all we have to value ourselves. And I think we have to recognize that what we do in the NHS is a job like no other. It's absolutely different from any other job. It's very different from being a lawyer. It may require many of the same skills as you're a doctor, but it's very different. And I think it's important to value yourself and take pride in what you're doing and recognize that ultimately one of the most important skills that we have that we don't use enough is one that we really need to use in the health service, and that is to learn to listen. And we don't listen enough, but actually we should be listening to our patients and listening to each other.
I think that's a beautiful thought to end on. And I'm so grateful for your time today and for these wonderful stories that you've told us.